In this breast augmentation study, papers written on implant size selection systems are compared. There are three types: tissue-based planning, which relies on breast measurements with no patient input on size; dimensional analysis, which also uses measurements but includes patient collaboration; and no measurements, just surgeon or patient preference determines implant size. The authors used the Miners scale to evaluate previously published studies on these three systems. The Miners scale is designed to rate the quality of non-randomized studies. The highest score achievable is 16. In this review, papers on tissue-based systems averaged 6 out of 16, dimensional systems 1.4, and the no measurement system 0. The authors conclude that tissue-based systems are superior based on Miners scale rating. However, the top three papers the authors go on to discuss in detail each had a Miners score of 7. One was a tissue-based system, the other two were dimensional system papers. This implies parity of these two systems. But here's the key point. While implying that a higher Miners score indicates a better system, it actually only measures the quality of the study examining the system, not the system itself. Therefore, the claim that tissue-based systems are superior based on a Miners score is not a valid conclusion. The authors also evaluated sizing system efficacy based on reoperation rates and concluded once again that tissue-based systems are superior. However, in the three papers cited to support this conclusion, all of which were co-authored by the senior author of this paper, they stress specific methodology for achieving lower reoperation rates, for which tissue-based planning is only one factor of many. A much more valid and relevant measurement of sizing systems would be to compare patient satisfaction using the BreastQ instrument, not reoperation rates. Contrary to the author's position, we have found that preoperative sizing is highly effective in our practice. It's virtually eliminated requests for size change surgery. Besides allowing patients to experience an accurate three-dimensional simulation, preoperative sizing also imparts patient ownership in the size selection process. Moreover, a recent survey of over 1,000 ASPS surgeons showed that this practice is popular and widespread. When given more than one choice of implant size selection systems, 100% reported using preoperative sizing, and only 20% reported using a tissue-based system. There are regional differences in average implant size. A more strict tissue-based system makes sense in geographic areas where the average implant size is perhaps 400 cc's or more, in order to reduce reoperation rates related to overly large implant size. On the other hand, in regions where average implant size is smaller, say 275 to 300 cc's, patients can be more directly involved with the size selection process, since preferred sizes are less likely to bump up against tissue-defined limits. For members of the public viewing this video discussion, the take-home points from this paper are the following. Surgeons have objective measures for determining the range of implant sizes that individual breast anatomy can accommodate. Follow the surgeon's advice regarding the upper limit of what the tissues can handle. To exceed recommendations can have both negative aesthetic consequences as well as increase the chance of needing additional surgery to treat implant-induced deformities.